Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for joining the Foundation's webinar titled Q&A with Dr. John Winkelman. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Winkelman will answer as many questions as time allows. After the webinar, you will receive an email with a link to the webinar recording. The webinar recording will also be made available in the member portal section of our website. If you are not a Foundation member and if you would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting that they have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. John Winkelman. Dr. Winkelman is Chief of the Sleep Disorders Clinical Research Program, Department of Psychiatry at Mass Gen Hospital in Boston, Massachusetts, and RLS Foundation Quality Care Center. Dr. Winkelman received his PhD from Harvard University in psychobiology and his MD from Harvard Medical School. He finished a residency in psychiatry and a fellowship in neurology, sleep disorder medicine at Mass Gen. He has served as chairman of several national organizations, including the Nosology Committee, the Movement Disorder section of the American Academy of Sleep Medicine, and the American Academy of Neurology Guideline Committee for the Treatment of RLS. Since 2000, he has served on the RLS Foundation's Medical Advisory Board, which is now the Scientific and Medical Advisory Board. Dr. Winkelman's research interests include sleep-related movement disorders, insomnia, and parasomnia. He's a leading expert in the field of RLS and has published several textbooks and authored over 100 articles in sleep medicine. Dr. Winkelman, thank you for being with us this afternoon, and we'll begin our question and answer session.
Wow, Carla, way to go.
I'm telling you, you are an accomplished man.
You didn't have to read all that, though. Okay.
Well, but just letting everyone know, you got it. All right, so we broke this down into sections, and we're going to start with opioids. First question, after covering for 19 years, Cigna has stopped covering opioids for RLS. What can I do?
You can, one, get new insurance, or two, ask your doctor about alternatives to the current opioid that you're using. The opioids, some of them are more expensive and some of them are cheaper. And for instance, OxyContin is one of the more expensive ones. Suboxone may be one of the more expensive ones. On the other hand, the generic medications are probably going to be cheaper. And I would guess that you're on one of the longer acting brand name agents. And so you may, one, want to see how much it costs to pay out of pocket for the medication. Sometimes insurance won't cover it, but it's actually quite cheap. Like with methadone, it's just a few dollars a month if you pay out of pocket, even though insurance doesn't cover it. So I'd find out how much it costs, and if it's too expensive to pay out of pocket, discuss with your doctor if there are any alternatives.
All right. If methadone has been effective for 6 months, how likely is it that methadone will continue to be effective for RLS?
In my experience, methadone continues to be effective over long periods of time. The dose in some people will go up over time. In our experience, about 50% of people will have some increase in dose over a 1 to 10 year period, although not a dramatic increase in dose. If your response to methadone changes abruptly, it's important that you and your doctor search for causes for why you might have become less responsive to the medication. So one possibility is that it's not getting absorbed as well. Another possibility is that your restless legs has gotten worse, either due to loss of iron, to addition of medication that makes RLS worse, like a serotonin type antidepressant or a dopamine antagonist or an antihistamine. It's possible that you developed another sleep disorder like sleep apnea. So first, look for things that make the RLS worse, that could make it less responsive to the dose of the opioid you were taking, and consider whether there's a possibility that you're absorbing it less well, possibly due to a lot of constipation. People who have a lot of constipation may poorly absorb their medications.
Okay. My mother suffers from severe RLS and is dependent on tramadol throughout the day and night. What other resources are available?
I'm not exactly sure what you mean by resources. Certainly in terms of information, I think the RLS Foundation has very nice resources for her, for she and her doctor to learn more about restless leg syndrome. If you're thinking about other treatments, because I guess that there's some side effects or there's unhappiness with the tramadol, you could discuss with your doctor whether an alternate medication, for instance, an alpha-2 delta medicine like gabapentin, pregabalin, or gabapentin enicarbol might be helpful. In general, if the tramadol is working and if the dose has been stable and if there aren't side effects, I'm not sure that I would, I'm a little bit of a kind of, if it ain't broke, don't fix it kind of a person. And without more information, it's hard for me to tell why other resources are needed for your mother.
Okay. Next question is, when all meds have been tried but opioids, and then they are hard to come by, what's next in treatment? I'm at the end of hope.
Okay. And I hear a lot of people in that situation where they have used a dopaminergic drug and have developed augmentation and have required an increased dose. And they've tried gabapentin or pregabalin, those are Neurontin or Lyrica, and either they didn't work so well or the side effects were bothersome. And they ask me, are opioids really the only alternative? I would say that at this point, they're the alternative with the best data in support of their efficacy, but there are other alternatives. Some people will use marijuana products, so that would be THC or CBD as alternatives. Some individuals, every person with RLS should have their iron checked, and if it is not within an acceptable range, either iron by mouth or intravenous iron is an option. And then there's simple things like stretching and exercise, which can be helpful in mild restless leg syndrome, particularly if they're done in the few hours, the stretching a few hours before bed, or the exercise earlier in the day can be helpful. But unfortunately, what we've got for restless legs are 4 classes of treatments: dopaminergic drugs, the alpha-2 deltas like gabapentin and pregabalin, iron by mouth or IV, and opioids. Those are really the proven treatments for restless legs at this point in time.
Okay. And then a quick question. What someone is wanting to know how they can get a prescription for opioids to treat RLS. And I think, I'd just like you to go over that.
How to get a prescription? Well, prescriptions need to be written by healthcare providers. I think in general, those probably need to be physicians if they're opioids, although I'm not sure about each state's rules about nurse practitioners. So you need to have a conversation with your treating physician. If they're not knowledgeable about restless leg syndrome, about the various treatment options, I would go to a sleep disorders center. Hopefully there's one near you. Even better, a quality care center. The RLS Foundation has a list of quality care centers, and review your history. Really a thorough evaluation and history of what you've taken and over the years for RLS, as well as relevant blood tests, need to be done before any prescription can be written.
All right, and next question is, would you be able to share some preliminary data from the opioid study funded by the RLS Foundation?
Of course. So we've got some really nice data at this point in time. To be clear, we only enrolled people who had RLS, diagnosis of RLS, and had a previous positive response to a dopaminergic drug. This is a way to, in our minds, assure that people really did have RLS. People had to be taking an opioid and couldn't be taking an opioid for any chronic pain condition. We've got around 325 people in the registry now. We have collected the data on the 300. About 60% are women. We have mostly Caucasians. We'd like to see a little bit more diversity in the population, but right now it's almost all Caucasians, usually, generally quite educated. And about almost 90% of people had previous augmentation to the opioids. About 50% of people in the registry are on just one opioid, and most of those people are taking methadone, although there are about 30% of people who are taking some kind of oxycodone preparation. Generally, the doses of the opioids that are being used are quite low, which is consistent with what the published literature to date shows. So somewhere around 7.5 to 10 milligrams of methadone, or about 30 milligrams of morphine. About a third of people are taking a antidepressant medication, 10 or 15% taking a sleeping pill. People have been using the medicines for anywhere from about a year to 5 years who are in the registry. We have seen about 50% of people over the period of time that they've taken the medicine, and here they're reporting retrospectively on their experience. About 50% have increased their dose over the 5 years, and the longer people have been taking it, the more they've increased their dose. But as I said, only 50% of people have increased. The other 50% have kept at the same dose level over time. People do have side effects. About 50% of people have constipation, and about a quarter have daytime sleepiness. Itching and sweating are also present as side effects. People's RLS is not completely treated, even though they're on an opioid. Average RLS score is in the mild to moderate range. About a quarter of people have an RLS score of 0, meaning no RLS symptoms. But if you look at the rest of the other 75% of people, they have mild to moderate symptoms. And if you ask them how they're doing on their RLS, most people say that they have mild RLS symptoms. Most people are not, when you ask them about risk for abuse, the vast majority of people have low risk based upon known risk factors. 50% of people, as I said before, have a lifetime history of psychiatric illness, the most common being depression and generalized anxiety disorder. One of the most interesting findings we've had has to do with suicidal thoughts. Between 35 and 40% of people had had abstract suicidal thoughts before starting an opioid. That means that they'd wished that they were dead or wished they'd go to sleep and not wake up. That was before opioid treatment. That dropped from about 37% to about 13% on the opioid, so that these abstract suicidal thoughts really dramatically were reduced with treatment. And people had, about 25% had had actual concrete thoughts of killing themselves. And so that went down from about 25% of people to about 5% of people on the opioids. So the opioids seem to not only address RLS symptoms, but give people address some of the helplessness and hopelessness, as well as the clear RLS symptoms that lead people to have these kinds of thoughts. So I think that those are the high points. As you may know, these are just the baseline data on the registry. The most interesting data will be present as we follow people over time, over a number of years, to see what changes, whether people continue to get benefit from the opioids, whether doses need to go up, whether side effects change, whether there's a reduction in RLS severity, and whether some of these suicidal thoughts, depression, anxiety get reduced or increased over time as people stay on the opioids.
Okay, great. All right, we're going to move into the questions that we have on iron. Do you have any suggestions on the amount of daily red meat that would be beneficial to ensure sufficient iron intake?
The amount of daily red meat. I guess it depends on how bloody it is. Because remember, when people get iron from meat, it's the blood, not to be too gross, but it is the blood that you're swallowing and absorbing that then gets broken down, and we use that iron. So I guess if you like your steaks or your hamburgers really rare, there's going to be more blood in there, and so you need less of it. Generally, we need 1 to 2 milligrams of iron per day to maintain equilibrium of our iron stores. Certainly, if you are iron deficient, you need more than that because you need to catch up. But if you are not a vegetarian and you think it's safe from a health perspective, I recommend that people have red meat a couple times a week to maintain iron stores. If you don't want to take iron by mouth in the form of a pill, if you want to take it in the form of a pill, somewhere in the 15 to 25 milligrams of iron per day, or even every other day, is what we recommend. Recent studies demonstrated that iron by mouth, there's really no advantage of taking it every day, that you can take it every other day and get about the same bang for your buck. And that might also address some of the stomach upset and constipation that people get with taking iron pills.
Next question, do you have any thoughts on the use of iron and its ferric carboxymaltose for patients with extremely severe RLS symptoms? And this person says, for question, iron below 100 micrograms per liter.
Sure. Well, this person has obviously read the guidelines that we recently published, or is at least aware of them. There have been at least 2, I think 3 studies with FCM, ferric carboxymaltose, compared to saline, i.e. placebo, showing that FCM is superior to placebo in individuals with RLS. In the guidelines, mentioned that the ferritin levels should be below 100 for those people. I would even say optimally below 75, although I don't think anyone has specifically looked or found that the lower your iron, the better you're going to do. There are a number of questions about iron treatment. Who is going to benefit from it most? Who, what level do you aim for? How often do you use iron infusions? These are all questions that remain unanswered at this point in time. But I think that if your ferritin is below, certainly below 75, but maybe even below 100, I think it's reasonable to try IV iron, including ferric carboxymaltose or one of the other IV iron brands. It doesn't have to be FCM, to see whether that's helpful. You should note that IV iron doesn't work immediately. You think that IV treatments are going to work like in 5 minutes or that night. Strangely enough, they seem to be most effective over a period of a couple of months. So you may really need to wait some period of time before you see that this treatment works. If you can't wait that long, then you may need to use some medication approach while you're waiting for the iron to take effect.
Okay. If the serum ferritin is below 50 and needs supplementation, what is the best iron formulation and least constipating? And is there a dose range there?
Yeah, well, I think I was just talking about the doses. I would recommend somewhere in the 15 to 25 milligrams of elemental iron. It's not clear to me that there's one iron preparation that's any better than any other in terms of how easy they are on your stomach. We do recommend that you take the iron in when your stomach is acidic, meaning empty of food and possibly even acidified by taking orange juice or a vitamin C tablet. But people need to do, if you say these things and people can't take the medicine because it upsets their stomach or gives them constipation, then you have lost the whole thing. So if you can take it every other day, I think that that's totally fine. If taking it every day is possible for your stomach and your GI tract, then I would try that as well. But I really can't recommend one particular oral iron formulation.
Okay. Next question. What are the guidelines for repeating the iron infusion if you received good results from the first one?
Yeah, I wish we had data on this. And we're hoping to in the next 6 months, because there is one trial that was a year-long study where people had the option of having repeat IV iron infusions. But at this point, I would say it doesn't make any sense to even get your iron tested until 3 months after you've had the IV iron, at which point, if you got 1,000 milligrams, which is generally the dose that we're looking for of IV iron, 1,000 milligrams, because one study with 500 milligrams didn't show superiority over placebo. So at 3 months, your levels are going to be quite high still, unless, of course, you are actively bleeding. So don't even bother testing for 3 months. And in my experience, sometimes people need a repeat infusion at 6 months after the original one. But I can't say we have any data, so I really don't want to speculate. I think you could have your levels done at 3 months and then 3 months later, and you just have to follow what those levels are telling you.
What role does hepcidin have in the workup of RLS?
So hepcidin is a compound that is released by the liver, and it when it's released, it blocks absorption and release from the organs of iron into the blood. And the idea is that it's there to prevent us from getting iron overloaded. Our body protects us, even though we're really concerned today in this context about not having enough iron. The body is trying to protect us from having too much iron, because too much iron is toxic. And hepcidin's role is to kind of be the iron police and not allow too much iron to get absorbed. We do not draw hepcidin levels, so it's important in iron regulation, but not part of the workup.
Okay, that's it on the iron questions that we received. So we're going to go into the medication questions. So they're just going to be a little bit of everything. The first question is, how do you feel about the use of kratom for RLS, and do you think it's okay to use it in the morning and at night?
I am not enthusiastic about the use of kratom. At this point, we don't understand how it works, what it is. It's something that you're buying without any understanding of its purity or what it's been cut with. I would really discourage people from using kratom to treat RLS, or for that matter, anything. It's I think I would consider it more at this point a substance of abuse than a medication. Maybe at some point in time we'll understand more about it, and we'll have some what's the word? We'll have some ability to know how much there is in whatever it is you're taking. But I would just avoid it at this point in time. I'm not sure why. There are enough medications to treat RLS without taking kratom.
Okay. I've been taking Requip for many years for RLS. I normally would sleep the entire night. Now I'm lucky to get 3 hours. Why this change?
It certainly sounds as if there could be augmentation. One of the features of augmentation is a reduced duration of benefit. And I see patients with this all the time who, just like you, said that he used to work all night long, and now they're waking up at 3, 4, 5 o'clock in the morning and have a return or rebound of RLS symptoms. And so this is one of the features of augmentation, which means the brain has adjusted to your giving it this dopamine agonist. And so either it's augmentation or there's something else going on. You could be iron deficient. You could have started a medication that makes RLS worse. You might not be getting enough sleep, which kicks things off. And then, as you can imagine, you get into a vicious cycle of worsening RLS. So I would go back to your doctor, say that it's not working as well. I would not just increase the dose at this point because your body's trying to tell you something, and I would listen and have your doctor listen as well.
All right, every day I have periods of anxiety. I'm not depressed or worried. Could oxycodone or Neurontin cause daily anxiety?
Every day that you have periods of anxiety and not depressed or
Worried?
Worried. So anxiety but not worried. Not exactly sure what that means. I guess you're saying that you have physical symptoms of anxiety, but you don't have the mental worry part of it. And what's the medication that is being taken?
Oxycodone and Neurontin.
Oxycodone and Neurontin. It's possible that it could be the oxycodone, and then in fact this anxiety is really a withdrawal from the oxycodone. Oxycodone is really short acting. Most people find that it works for about 4 hours for restless legs, and it's possible that if you're taking a high enough dose for a long enough period of time, and that you're having between dose withdrawal, which is manifesting itself, you experience as anxiety. And so you may want to look up and see if you can just look up withdrawal symptoms from opioids and see if you're having some of those, in which case I would certainly discuss with your doctor saying that you're having between dose withdrawal. It's also possible that you've developed an anxiety disorder. It's nothing to do with the medications. Anxiety disorders are quite common. And so I would certainly have a conversation and try to figure out, is it medication withdrawal? Is it just that you have an anxiety, you've developed an anxiety disorder, you know, like panic attacks or limited symptom panic attacks? But this is what we do in medicine, is we see people who've got things going on, and our job is to ask lots of questions and try to figure out the cause.
Okay. Next is, I was put on Wellbutrin and the restless legs went away completely. After a few months, it came back. Why is this?
Why is this? There's been one study of bupropion or Wellbutrin for RLS, and interestingly enough, the study found similar things to what you experienced, which was at 6 weeks, it was helpful for restless leg syndrome, but then at, I can't remember if it was 10 weeks or 12 weeks at the end of the study, it was no longer better than saline. Not saline, than placebo. And bupropion is a weak dopamine and norepinephrine reuptake inhibitor. So it increases the activity of dopamine in the nervous system. So you could imagine that it might be helpful for restless leg syndrome. And you could imagine that people could get augmentation possibly with it. And you could also imagine that it was just strong enough to beat your RLS at the beginning, but that over time it lost some of its benefit, and now your RLS has got the upper hand. So that would be a reasonable explanation. We do not use Wellbutrin as a treatment for restless leg syndrome, so you may need to talk to your doctor about other accepted RLS treatments.
Okay. Are there any natural treatments for RLS?
Natural. Well, let me think about that. I think that mild exercise is a nice treatment generally for more milder forms of restless leg syndrome. It seems as if no exercise is not good for RLS. Too much exercise is not good for RLS, but there's some kind of Goldilocks level of exercise that is helpful for RLS. We call these an inverted U-shaped curve. So low, and then as you go up, it gets a little bit higher, and then as you go up further, it goes back and not being helpful again. In addition to exercise, let's think about this. There's some suggestion from early literature that magnesium was helpful, but those studies were not compared to placebo, so I really don't think we can put much faith in them. I unfortunately can't think of anything else, I guess, other than iron, obviously, which is a natural I guess, as a natural treatment. And if your iron is low, taking iron by mouth, and if it's at an intermediate level, possibly getting IV iron. But I wish that there were more treatments that people could do on their own that didn't require medical intervention. But at this point in time, we don't know of any others.
Okay, since we're talking a little bit about walking, why does walking for 10 minutes before bedtime buy me 2 to 3 hours more sleep?
Yeah, it's true. I do hear this from people. Stretching, walking, get a little activity on a bicycle, stationary bicycle, can all be helpful. We know that restless leg syndrome starts when people are not moving, and it is made better by moving. So it's as if you can kind of build up some exercise amount in your body, which staves it off and then allows you to get to sleep. Unfortunately, for some people, that exercise benefit wears off after some period of time, for you 2 hours, and then the RLS is still there and wakes you up. So it makes sense that exercise would be helpful, because not moving is bad is by definition bad for RLS, and moving by definition is good for RLS.
Okay. Next question. Is it normal to take ropinirole and gabapentin for RLS? They seem to do different things.
Yes, it is normal.
Yes.
They work in different ways, which is good. And so oftentimes in medicine, we will use treatments that work by different mechanisms as a way to treat, even cancer, or lots of different cardiac problems. You will use 2 different approaches so that the body responds better. And this combination of a dopaminergic drug and well, I've been calling them alpha-2 deltas, the gabapentin or pregabalin, that approach is a common one. And the good thing about it is that the alpha-2 delta, the gabapentin, is pulling a lot of the weight, or pulling some of the weight, so that in treating your RLS, so that the dose of the dopamine drug can be kept low. And we know that the lower the dose of the dopamine drug, the less likely you're going to develop augmentation, which is our goal with those medicines, is to avoid augmentation. So using the alpha-2 delta to keep the dopamine agonist dose low makes perfect sense, and I do it all the time.
Okay, someone also asked the same question with using pramipexole. So I think we just need to remind them that pramipexole and rotigotine are in the same class of drug.
And ropinirole. I think it was ropinirole in the last question.
Yeah, correct. Yep. So we just wanted to go up there.
Yep.
To replace dopamine agonist, Horizon and Nupro are often prescribed. I'm reading this, and both meds are terribly expensive. Are there any hope for generics?
There's always a hope for the generic. It's just a question of the patent. And I think that both of those probably have a relatively long patent, so you're going to be waiting a while. The good news is that Horizon is a good medication, but it is just a medication that fools the body into allowing gabapentin to be absorbed more predictably, so that you, rather than using Horizon, if it's too expensive or if your insurance company won't cover it, you can just use gabapentin. And the key with gabapentin to get to the higher doses is to split the dose. Rather than taking 1,200 milligrams before bed, I recommend taking 600 milligrams at 8 o'clock and then another 600 milligrams at 10 or 11 o'clock. That's going to be much better than taking 1,200 milligrams all at once. And that's kind of what the Horizon does, is allows the gabapentin to be better absorbed and more reliably absorbed. And gabapentin, as opposed to Nupro and Horizon, is dirt cheap.
And there are also prescription assistant programs. If you drop it into Google, they'll come up, or you can call us at the foundation and we'll help you find that information.
Those prescription assistant programs are very nice. Unfortunately, they don't work for anybody who has Medicare or Mass Health or Medicaid. So many of my patients are above 65 and have Medicare, and so it's not so helpful to them. But if you want to take an alpha-2 delta, you've got a very cheap option in gabapentin.
Right, and GoodRx is another one. And then sometimes Costco and Sam's will offer those at a discounted price too. So some ideas to find those meds at a cheaper price or different formulation. Can I ask my doctor to prescribe something to help me when I have impossible nights that nothing works?
When nothing works. Well, if nothing works, then nothing works. But I would say that in those people who the most reliable and the medicines for restless leg syndrome are the dopamine drugs. They work generally pretty quickly and in almost everybody. However, if you use them over the long term, this augmentation develops where restless legs get worse. So if you can use a Horizon or a gabapentin or a Lyrica or even an opioid, but you still have occasional bad nights, or let's say you're going to go on a long plane trip at night, I will suggest to people that they use Ropinirole Requip on those unusual occasions to address those really difficult times. And if you just use one of these dopamine drugs on an irregular basis, just occasionally, there's no suggestion that you'll get augmentation from occasional use. Opioids also work quite quickly and quite well. And so talking to your doctor about how often you would want to use these medicines, making some agreement with them that you'd only get, let's say, 3 or 4 pills a month for one of these medicines will then allow you to have something available that treats those terrible, terrible nights, but allows you and your doctor to be comfortable that you're using the medication in a way that will not lead to long-term problems.
Okay. What is the mechanism of action for the drug Horizon?
Horizon is a controlled release prodrug of gabapentin. So as I mentioned before, gabapentin is erratically absorbed, particularly at higher doses. And Horizon allows gabapentin to be absorbed in a predictable way, number one, and to be long acting so that you can take it just once a day and it remains effective throughout the day. But its mechanism of action is the same as with gabapentin.
What medications would you advise for a patient with RLS who has never been treated with prescription medications?
Well, first you go to your doctor and you get a good workup, and you make sure that you're not iron deficient. You make sure that you're not taking medications that make RLS worse. the serotonin antidepressants, centrally acting antihistamines like Benadryl, dopamine blocking agent, and that there's no significant sleep apnea that could be responsible. So you want to try to treat underlying causes when possible. If those are not present, the iron deficiency or the medications, then in general, we try to start people on one of these alpha-2 delta agents, that being gabapentin, gabapentin enacarbil, or pregabalin, because they are not associated with augmentation. In some individuals, we might start with a dopamine drug, but we have a conversation. I have a conversation with the patient and discuss the long-term risks of the dopamine agonists, the main one being augmentation, a worsening of RLS. And it's a conversation between the two of us that would lead us to decide whether to use a gabapentin type drug or a dopamine agonist.
Okay. Who is the best to treat an RLS sufferer? A general practitioner, neurologist, pulmonologist, other suggestion, or combination of the above?
I think their original training is not as important as whether they have experience treating RLS specifically. So I know pulmonologists who are quite knowledgeable about RLS. I know psychiatrists who are quite knowledgeable about it. I know neurologists who are not knowledgeable about it. So it's hard to generalize, and you really need to, you're probably going to need to start with your primary care doctor and ask them, do you have a lot of patients with restless leg syndrome? Do you feel comfortable treating it? You know, how do you manage augmentation? Just kind of general, do you know what augmentation is? Just general questions. And if you're not satisfied, you could say to them, you know, I'd really like to see a RLS specialist. Can you identify anybody in our community who does that? Or contact the RLS Foundation, who is a list of doctors who are knowledgeable and or even more expert in the treatment of restless leg syndrome.
Okay. Next question. Are foot, ankle, and calf spasms related to RLS? They occur in the bed, are painful, and can be difficult to eliminate at times.
Yes, these nocturnal leg cramps are really annoying and really common. They're certainly more common as people get older. Their relationship to restless leg syndrome is unclear. So it may be that I've hypothesized that when people have periodic leg movements of sleep, which people with restless legs do have while they're sleeping, that one of those leg movements may evolve or turn into a leg cramp. So that would be some association there. The treatment of nighttime leg cramps is uncertain. Previously, the #1 treatment was quinine, but that has now been taken off the market in the United States because there is a rare but very serious side effect where people's platelets get destroyed and they have problems with bleeding. So quinine does not exist on the market other than in tonic water. Some people will use gabapentin for nocturnal leg cramps. Other people find that stretching before bed can be helpful, like a runner's stretch. So hands against the wall and feet initially flat on the floor and then heel up to stretch the calf before bed. But I understand your frustration because those leg cramps are very disturbing, but it's not clear whether there's an association with RLS other than both nighttime leg cramps, and restless leg syndrome are more common as people get older.
Does RLS worsen as you age?
We think so. It's hard to do that study because you need to identify people with restless leg syndrome and then follow them, and people without restless leg syndrome, and then follow all of them for 5, 10, or 20 years and see if it gets worse, and not treat them, of course. And so those kinds of studies are really not possible to do because people want to get treatment for the restless legs. They don't want to be in an experiment for 20 years. So we think that it does get worse with age, but I would say that we're uncertain. There are also people who have seen where their restless legs did get better with age, or fluctuates better and worse and better and worse. So there's all kinds of patterns that we see over time with increased age.
Is there any connection between RLS and Alzheimer's?
None as far as I know.
Any hope for RLS improving over time? You kind of touched on that, but
some people's RLS, there's one study that was done in Japan where they did follow people untreated over, I think, 3 to 5 years. People with mild restless legs, 50% of them had disappearance of their RLS over time. People with severe RLS at the beginning, only like 10% of people had disappearance over time. So the more severe your RLS is, the less likely that it will disappear.
okay. Are there any dietary triggers for RLS?
I've heard lots. You know, I treat hundreds and hundreds of people with RLS, and I've heard just about everything. People saying that sugar, I guess the most common is that sugar makes it worse, dehydration makes it worse. But I think most people that I talk to do not find that there's any particular thing that they can avoid that will make it worse. I think anything that's going to keep you up at night and make it harder for you to fall asleep is going to increase the likelihood that your RLS will rear its ugly head. Because if you can get to sleep in 10 minutes before your RLS gets you, because RLS wakes up when you lie down, so the longer you're lying there, the more likely that the RLS will get you. So you want to avoid things that you know will interfere with your ability to fall asleep. So caffeine, and for some people that's sugar. I would say even just lying there awake in bed for long periods of time, not being able to fall asleep, is not recommended. If you're not sleepy, you shouldn't be in bed. And so lots of other things to do in this life other than lying down and trying to go to sleep. And if you really finding that you're not sleepy, just give it a break. Do something else that's relaxing and distracting for half an hour or so, and then go back to bed and then try it again. But don't lie there trying to squeeze it out and trying to fall asleep, because if you wait too long, your RLS will get you.
Okay. There are reports that ivory soaps applied to the legs or a bar in the bed relieves RLS symptoms. Can you comment on this?
I think those reports primarily came from Colgate-Palmolive, who market that drug. All I can say is that the slogans, fresh and clean as a whistle, are very nice slogans, but I would not put much faith in Irish Spring working for your RLS. For those people in the audience who Irish Spring has worked for you, I would say that that's wonderful. You're very lucky people, and I would continue using the Irish Spring. But for those people who have not used it, who have RLS, I would try proven treatments first.
Why do people get RLS during pregnancy?
It's those doggone babies. When women are pregnant, the placenta, which is feeding the fetus, gets first dibs on a lot of the good things that are circulating in the blood, and that includes iron. So the fetus, the placenta, and then the fetus are sucking iron away from the mom, and it's probably a function of the iron deficiency that's associated with pregnancy. There may be other causes, but I think that's the best theory.
Okay. Can depression be a result of RLS? If so, what depression meds are best for RLS patients?
You are sure. Well, there have been studies that suggest, and I was the author of some of these, that RLS does increase your risk of developing, RLS increases your risk of developing depression. There are also studies that show that depression increases your risk of developing RLS. So we call this a bi-directional relationship. The arrow goes both ways. It's like a circle. 2 points on that circle. One is depression, one's RLS, but it goes round and round and round and round, and one makes the other one worse. So there are high rates of depression in people with restless leg syndrome. I see this all the time, not just because I'm a psychiatrist or ask about mood and depression issues, but it's been shown in the literature many times. We generally recommend bupropion or Wellbutrin as the first line depression treatment. However, depression is a serious illness, and if you need to use an antidepressant other than Wellbutrin, one of the serotonergic antidepressants, because you're feeling very depressed or even suicidal, you gotta go with that treatment. It's important to treat the depression. We can always figure out a way to treat the RLS, but depression needs to be taken seriously. And I would never forego depression treatment because of the concerns about worsening RLS. But in general, first line treatment, we recommend Wellbutrin or bupropion.
Okay. What is the role of magnesium in RLS?
Probably none. One study done 20 years ago that was done without placebo suggested that in the 11 people or so that were in the study, that half of them, or a little bit more than half of them, improved with magnesium. Unfortunately, placebo is a powerful, or maybe fortunately, placebo is a powerful treatment for restless leg syndrome. Many people think the placebo works by increasing dopamine in the brain, which is why restless leg syndrome would get particularly better with placebo. So in general, anybody is welcome to try magnesium as a treatment. Just be cautious of the fact that magnesium produces diarrhea, which is where you get milk of magnesia, as a treatment for constipation and other kinds of stomach upset. So you want to not take too much magnesium, or else you'll be sitting a lot and on the toilet, and then it's going to make your RLS worse. So I'd say it's worth a try, and if it works, that's great. There may be some people for whom magnesium is particularly effective. At this point in time, I would say it's an unproven treatment.
Okay, and our last question is, what is the current state of research on the causes and cures of RLS?
You saved that for last, Carla?
I did.
Okay. The causes and treatments, you said?
The causes and cures of RLS?
Causes and cures.
Mm-hmm.
Wow. We know that there are two things that are involved in as potential causes of restless leg syndrome. One is genetics, and we've identified a number of genes that do seem to contribute to increased risk for developing RLS. There may be as many as 15 or 20 genes that contribute. So there's no one genetic test for RLS. And even when you combine all 15 or 20 of these genes, it still doesn't account for the majority of people with RLS. So we've got an interaction of the gene and some feature in the environment that causes RLS. The second thing we know about cause, or we think we know about cause in RLS, is iron deficiency in the brain. Now, we can only assess iron deficiency in the brain with specialized imaging techniques, so it's not something you can do at your doctor's office or in a laboratory, but it appears that low brain iron increases the risk of RLS, and that if we increase iron by taking it by mouth or intravenously, some percentage of people, certainly not everybody, will have an improvement in their RLS. So those are the two main things we know. I'd say at this point, we're really not even close to a cure, but we're very, very lucky in that we've developed 4 FDA-approved drugs in the last 20 years. When I started doing RLS research 25 years ago, there was nothing. And few doctors even knew what RLS was. And at this point in time, we know about 2 important causes or potential causes. We've got 4 FDA-approved drugs, and we've got other drugs that we think are effective, but are not even FDA-approved. So we've got a variety of options. So we're really in a pretty good spot, even though there are clearly a lot of people who are still suffering.
Okay. Well, thank you so much. I appreciate everyone, Dr. Winkelman, for staying on extra time, and everyone else on the call. It was a great webinar, and we covered a lot of territory. So I wish everyone a great afternoon. And again, thank you, Dr. Winkelman. Excellent work here.
Thank you, Carla, and I appreciate everybody's attention.
All right, thank you.
Bye-bye.
Bye-bye.